Good afternoon. It's really a great pleasure for me and a privilege to have the opportunity to introduce today's closing keynote speaker, really an extraordinary scholar, colleague, and a very valuable friend of mine, Dr. Drew Westen. Dr. Westen is currently professor in the departments of psychology, psychiatry, and behavioral sciences at Emory University, and he is also the director of the clinical psychology program there. Dr. Westen has taught previously at Harvard Medical School, Boston University, and the University of Michigan, where he received his doctoral degree in clinical psychology. While still a graduate student, Drew published his first book, Self and Society, Narcissism, Collectivism, and the Development of Morals. Very light reading. Dr. Westen was the recipient of Michigan's first Golden Apple Award for outstanding undergraduate teaching. It's also worth noting that Drew was selected the best professor at the university by the Michigan Daily for 2 consecutive years. Dr. Westen has received numerous awards and honors. It's impossible for me to list all of them. They're extraordinary. But I will say that he received the first annual award from Division 12 of the American Psychological Association for his contributions to the understanding of personality, the Distinguished Contribution to Research Award of Division 39 of the American Psychological Association, and the Boyer Prize from the American Anthropological Association Society for Psychological Anthropology. Professor Westen has written over 150 scientific papers and currently holds multiple grants from the National Institutes of Mental Health, including 2 recently completed on adolescent personality pathology and a classification of personality pathology in adults. He is currently principal investigator on an NIMH Center grant on biological and psychosocial predictors of treatment response in first episode major depression and a follow-up study on predictors of relapse. Dr. Westen continues to be an active researcher in the areas of personality and personality disorders, particularly borderline personality disorder, as many of you know, adolescent psychopathology, eating disorders, unconscious mental processes, and the regulation of affect. And I want to add that Drew's work utilizing Q-sort procedures for constructing an empirically based and clinically relevant prototype diagnostic system for personality disorders will have a significant influence on the reconfiguration of Axis 2 in the forthcoming DSM-5. Really exciting work there. When not lecturing, teaching, or involved in academic writing, Dr. Westen somehow finds the time to be a frequent and respected contributor to the Huffington Post and a regular commentator on NPR. In addition, Drew has been an invited speaker for the Democratic Caucus of the U.S. House of Representatives and the U.S. Senate. Heaven knows they can use your advice. Drew's most recent book, The Political Brain, The Role of Emotion in Deciding the Fate of the Nation, has been widely credited with influencing, to a significant degree, the U.S. elections in 2008. Dr. Westen's presentation today is entitled Personality and Depression in College Students, Opportunities for Early Intervention and Treatment. Please join me in welcoming Dr. Drew Westen.
Well, thank you, Dr. Kellum, for that introduction that is very difficult to live up to. I can't believe that Fred actually gave that introduction with a straight face. I mean, we've known each other for a long time, so there's all kinds of dirt he could have dug up, and I'm so pleased he chose not to do it. It's a pleasure to be here, and I want to thank you all for inviting me to come back home to Ann Arbor. I spent many fond years here. Actually, in this building, I can remember a couple of particularly, one fond moment and one not so fond moment. The fond moment was Fred mentioned when I got the Golden Apple Award, they asked you to deliver what they call your last lecture, which is if you're picturing the last lecture of your career, what would it be? I think that was actually a polite way of saying, would you please deliver your last lecture and go? But the other was, this one's not such a fond memory of, I remember being upstairs somewhere in the Rackham building where that woman with the red marker was going through my doctoral dissertation, saying, and with the ruler and saying, I'm sorry, but you're off by 1/2 millimeter. You'll have to retype the whole thing. So many funny, fond memories of being here at Rackham. Anyway, and she was, I believe, the greatest contributor to depression among graduate students at Rackham and at Michigan of anyone in the entire city. So with that introduction, what I want to talk about today is something that is often not talked about because it's seen as stigmatizing. What I hope to do is to both talk about it and to destigmatize it today, and that is personality and depression in college students and how it presents opportunities for early intervention as well as treatment. I want to acknowledge a few people, my co-authors and collaborators in my lab back in Atlanta, as well as in Cambridge, Massachusetts, where we have a site. The generous support we've received from the National Institutes of Mental Health, and just a disclosure that the instrument that Fred mentioned, the personality and personality disorders instrument that I'll be talking about that we use for some of this research is under beta testing for potential commercial use. So I've just made Senator Charles Grassley happy that I fulfilled the requirement at full disclosure in a way that he has never done before he casts votes on health bills. Oh, excuse me, I didn't say that. First question is, you may be asking, what is, for those of you who are not experts in personality disorders, the difference between personality and personality disorders. I'm going to talk more broadly about personality pathology today for reasons that you'll see in a moment. I mean, basically, the difference is that personality is what you want to have and personality disorder is what you don't. Most of us, to be fuel efficient, are some kind of hybrid between those two. But why does personality pathology matter? Well, the best estimate suggests that somewhere in the neighborhood of 10 to 15% of the U.S. population is afflicted with personality disorders. That's a very, very high percentage when you think about it. And the other 85% of the population is afflicted by the 15%. So what that means is we're talking about a fairly significant mental health problem, and one that, as we'll see in a moment, is not confined to people. They don't develop it right after they get out of college. Nor do they develop the very sub-threshold forms of personality pathology that contribute to depression in college students, just like they contribute to it in high school students and in people in their 20s and 30s, all the way up through their until the day they stop torturing the people around them. No, the day they feel intense distress. So anyway, Thanksgiving dinner, do the math. Look to your left, look to your right at your next Thanksgiving dinner, and at least someone 2 over probably has a personality disorder, and the person either in your seat or next door probably has personality pathology of some sort. Personality pathology constitutes a diathesis or vulnerability factor for mood, as well as, I should note, anxiety and eating disorders, impulse disorders in adolescents and adults. It predicts the development of mood disorders from adolescence to early and mid-adulthood, and there's some fascinating research by Pat Cohen and her colleagues in New York, which has found that actually that personality pathology, having a personality disorder diagnosis in adolescence, which you're not supposed to do in DSM-4, I suspect you will be supposed to do it in DSM-5 because the evidence from her group, as well as from my lab, as well as from others, is now clear that personality disorders are highly diagnosable in adolescents in reliable and valid ways. I'll show you some data on that momentarily. But her researchers found that actually the presence of a personality disorder diagnosis is a better predictor of whether someone will develop in their early 20s a major depressive disorder or major depressive episode than is having a major depressive episode in adolescence. So we're talking about pretty strong predictors of depression. And just as importantly, personality pathology moderates the response to many forms of treatment for multiple disorders, including mood disorders, and it predicts relapse and depression in ways that we're just beginning to understand. The project that we have going at Emory right now, I'm a co-investigator on it. It's a center grant. Is in fact studying. We're studying everything from PET and fMRI and genetic predictors to personality predictors of response in first episode major depressed patients to try to see if we can figure out who's going to respond to what kind of medication or to cognitive behavioral therapy and see if we can predict relapse as well. So those are reasons why personality matters and matters in college students as well. And that raises the question to adolescents, including late adolescents and early adults, do they have personalities? This is a question that often gets asked. As soon as you talk about personality pathology in adolescents, people say, well, aren't you pathologizing people who don't yet have a fully developed personality, etc.? And it is, in fact, true that personality is not fully developed at age 5. It's not fully developed at age 18. There is some stabilization around age 30 from which you can predict, at least from trait models, for a long time after that. But do adolescents have personalities? My answers to this are very, very empirical. First, ask any parent. Second, ask any professor. And third, ask anyone treating depressed college students, and you will know that, in fact, adolescents have personalities. But aside from that, I'll show you some data shortly. What's wrong with the way we diagnose personality now? Well, a number of things are wrong with it, and these are true. These are even more true of late adolescents and young adults than they are of the rest of the people we treat. And the reason they're even more true is because the diagnostic classification system for personality disorders in DSM-4 and all the prior editions of the DSM was based completely on the study of adults with personality pathology. And when you're talking about 18-year-olds, 19-year-olds, you're not talking typically about fully formed adults, although it depends on which law you're referring to. For drinking, you're not. For joining the military, you are. But most of us know that adulthood is one of those things cognitive scientists call a fuzzy set that has its onset somewhere between, depending on the person, 16 and 65. So what's wrong with the way we diagnose personality disorders now? Well, the first and probably most important, that if there's anything that all personality disorders researchers agree on, and that's not much, but if there is anything they agree on, it is that categorical diagnosis is problematic. And that simply means, and this is true across many, many areas of psychiatric functioning, is that categorical diagnosis is problematic. That is that you don't either have or not have a personality disorder much of the time, and I'll talk about subthreshold disorders in a moment. Colloquially, clinically, we don't typically, we'll often say that someone has features of this or that personality disorder. We may say that someone has the disorder, but by which we mean either that we consulted the DSM and they met the criteria, which is usually not the way we diagnose, or that they match a prototype in our mind and we say, oh yeah, this patient has borderline personality disorder, this person has avoidant personality disorder. But much of the time we're talking about a continuum and multiple continua. Second problem is comorbidity. If you use a structured interview or semi-structured interview like the SCID-2 to diagnose personality disorders, patients who receive any diagnosis at all typically receive 3 to 6. Why is that 3 to 6 diagnoses? Why is that a problem? Well, it's a problem because there are only 10, and one of those is NOS. So if you think about it for a second, it's kind of like going to your doctor because you've got some congestion and a bunch of gunk in your throat, and your lungs aren't feeling really good, and your physician says, well, I'd say you have either the common cold or bronchitis or emphysema or lung cancer. We'll call it mixed mucus disorder, not otherwise specified. So that's kind of the state of personality disorder diagnosis in research. And it's actually a serious problem because I just, in preparing for this lecture, I caught myself back up on the literature on depression and personality disorders and what predicts relapse and what predicts next onset of an episode, the predictors are relatively non-specific, except that we know with each additional personality disorder criterion met across all of the personality disorders is a greater likelihood of relapse. So it's not as if any particular disorder, other than borderline, which is the one that is the best predictor, avoidant is the second best predictor, probably because it's the sloppiest diagnosis in DSM-4, and it's just messy and it includes a lot of borderline patients in it. But for whatever reasons, borderline personality disorder is a very strong predictor, but comorbidity is a serious problem. 40 to 70% of patients in the community have quote-unquote sub-threshold personality pathology, which means that many college students, for example, will come in because they have problems with rejection sensitivity that are related to their depression, or they're perfectionistic, or they have very high goals for themselves that they can't meet. Those are sub-threshold phenomena. Rejection sensitivity, the only way to code it in Axis 2 in DSM-4 is as one of the criteria for borderline personality disorder. But most of the depressed adolescents who you treat or depressed college students who you treat who have rejection sensitivity as an issue don't have borderline personality disorder. They don't even have particularly strong borderline features. That's part of an attachment style or a form of configuration of personality pathology that may have nothing to do with borderline personality disorder at all, and there's simply no way to code it. Memorability is a huge problem with all of the DSM, but certainly with personality disorders. I mean, I've done research on personality disorders now for over 25 years, since the time I was a graduate student here at Michigan. And I have to say, if you were to ask me to list the number of criteria for, say, schizotypal personality disorder that need to be met in order to diagnose someone with schizotypal personality disorder, not only could I not tell you the number, what's the threshold, because it's different for every disorder. Is it 5 out of 8? Is it 5 out of 9? Is it 4 out of 7? It varies for all the disorder, which makes memorability absolutely impossible. But I can't even tell you exactly what the criteria are. I could give you a few. Now, if I'm an expert in this, and that's really seriously a problem that I can't generate the list. And that's true of many disorders, but personality disorders, because there are 10 of them, and they all have very variable criteria that don't hang together in a meaningful way. That's a serious problem. The minimization of clinical richness of criterion diagnoses that has come with the efforts to make diagnoses more reliable. This is a huge problem as well. If you read the personality disorder diagnoses, none of them have more than 9 criteria. The problem is that these are multifactorial, highly complex, the political term is nuanced, disorders. So the problem is that if you've got only 9 criteria, you're not possibly going to be able to capture the richness of what the phenomenon is. All you're going to be able to do is give people a list and say if they make 5 of 9, you'll give them the disorder. And in the process of trying to get to reliable disorders, where you can give a structured interview and ask people direct questions about their personality, what you run into is the problem that you end up throwing really important criteria out. We found, for example, in one study after another, I'll show you one today, that the tendency to perceive negative qualities in other people that are really negative qualities about yourself is actually one of the most highly characteristic and diagnostic criteria for paranoid personality disorder. But it's left out of the and clinicians have known this for years. But that's left out of the diagnostic criteria for the disorder because you can't ask people about that in a structured interview or a questionnaire, and it's very difficult to get inter-rater reliability the usual ways that people try to do that. And I'm going to show you a very different way that you can do that you can, in fact, get reasonable reliability on it. Minimizing clinical inference has had other unintended consequences. I'll start with empathic psychopaths. Did you know that the diagnostic criteria for antisocial personality disorder does not include lack of empathy? That happens to be, if you just look empirically, and we've done this now in multiple studies, multiple large N samples, that the most diagnostic criterion for antisocial personality disorder out of the 200 potential criteria we've studied over and over and over with different samples of even items is always lack of empathy, but it's not included in DSM-4. Why? because it's a criterion for narcissistic personality disorder. And if you include it in narcissistic and antisocial, the quote-unquote comorbidity among those disorders jumps so high that you can barely distinguish the disorder. There's already a 0.5 correlation between the two disorders. So that's a problem. Whatever happened to passive-aggressive personality disorder? This is a great story, which is that the reason why we got rid of passive-aggressive personality disorder in DSM-4 is essentially, if you'll forgive my language, the bastards wouldn't show up for their interviews and research. That's why we don't have passive-aggressive personality. I mean, to take it a step further, it's also that if you ask people questions that are aimed at getting at passive aggression, you're likely not to get very good self-reported answers. You know, do you find yourself in a situation often where people are just getting pissed at you for no reason? And probably it's because of something that you did, but you don't know what it was. I mean, there isn't an easy way to ask about passive aggression, but you know it when you see it. It's kind of like the Supreme Court's definition of pornography. So here's the problem. That's why passive-aggressive personality disorder is not in DSM-4. Now, I might add that it's worth noting that if, in fact, it was removed from DSM-4 from DSM-3R, if, in fact, in 1994, we actually did eliminate passive-aggressive personality disorder, that has to be one of the great unheralded public health feats of the 20th century. And you know, whatever psychiatry did to do that was really an extraordinary phenomenon. I just wish a few of my colleagues would know that they don't exist anymore. Another problem with the way we currently diagnose personality is that clinicians don't use it. They don't use it for a lot of reasons. One of them is stigma, and that's especially true in college students. My guess is that a lot of you who treat college students never make a personality diagnosis, and the reason is that you don't want it carried with that student for a number of years afterwards. Here's another problem. Imagine yourself actually following the diagnostic manual. I'll sometimes do this just for fun at grand rounds when I'm giving it somewhere or other. I'll ask people to raise their hands if they've seen an Access 2 patient in the last, say, 3 months. Everybody raises their hand. And then I'll say, how many of you diagnosed them the correct way prescribed in DSM-4, which is to actually go through each of the criteria for all of the personality disorders, count up the number of symptoms met, and see which ones they're above threshold on. I think in 15 years of asking that question, 2 people have said yes, and they were PGY2s. They were beginning residents. No one else does it that way. And who also had OCD and thank you, Dr. Graydon. Absolutely, they had OCD. They probably had OCPD also. So it's just a huge problem. And I mentioned before the algorithms that vary by diagnosis just make it extremely difficult. Failure to address personality strengths is a huge problem with DSM-4 with Access 2. When you are working with a patient, whether you're treating them biomedically, whether you're treating them psychotherapeutically, whether you're doing both, you need to know who your ally is. You need to know what their strengths are as well as their weaknesses are. And I hope DSM-5 will include a personality strengths measure as well as measure as well as just focusing on personality pathology, and I'll show you some data on that in a few minutes. I should add that if you just use a multiple regression model and add a personality strengths index to all the personality disorder diagnoses, you see a jump of about 0.3 in your multiple R. It's a huge increment in prediction of, say, adaptive functioning, of likelihood of making a suicide attempt, of likelihood of getting arrested, etc., of social support, of ability to get along in relationships, of ability to do well at work. Finally, the way Access 2 has been implemented has actually never been tested against alternatives. I'll show you one alternative which is being sort of tested in DSM-5 by the work group, but not quite in this way. But this is a way that many clinicians think of personality disorders, and that is, or personality pathology, and that is in terms of, on the one hand, you've got multiple ways that you can have personality problems, or multiple personality styles or configurations that are problematic, and then you can have them at different levels of pathology. So, for example, narcissistic personality. You've got a style of being disordered, but then you've got anything running from the sort of neurotic to healthy range all the way down to the severely personality disordered range. So what you've got, for example, is at the lowest levels, you've got what people have often called malignant narcissism. We find this actually when we subgroup, empirically, we subgroup patients with narcissistic personality disorder. This is really probably on a psychopathy spectrum as much as on a narcissism spectrum. It seems to be somewhere at the intersection empirically. Then you've got above that slightly higher functioning narcissistic personality disorder, which often comes along with features like a fragile kind of narcissism, where the person is beneath the surface of their grandiosity. They have feelings of inadequacy, and I'll show you some data on that in a moment. Interestingly, we don't find that in the malignant narcissists. They don't have any kind of that sense of vulnerability that's underlying that grandiosity. It's a pure grandiosity that does not appear to be defensive. Then you've got above that the sort of your garden variety narcissistic neurotic. Someone you pour in a pound of grandiosity and a cup of entitlement and maybe a dash of narcissistic rage, and you've got someone who probably does really well at their work. They probably run a large corporation or country. They may be able to maintain long-term relationships, particularly if they have a fairly forgiving spouse or partner who puts up with it, or who has pathology of his or her own that allows this person to put up with it. But this person has many strengths as well as weaknesses, and then of course you've got the higher functioning, more common variant, which is the academic male. So, alternatives for DSM-5. There are a number of alternatives being considered. I won't get into the politics of all that, other than to say that I think it's, as someone who spends much of my time working with politicians, and by the way, it was an easy jump from personality disorders to politicians, but that isn't quite what the jump was about. But as someone who spends a lot of time in Washington, I will tell you that the politics of DSM-5 on Axis 2 probably are as heated as the politics that you see in Washington, D.C. But there are a couple of alternatives that are on the table. One of them which really isn't on the table, which is business as usual, which is to keep the system as it is. I think it's fair to say that will not be the case in DSM-5. Personality disorders are likely to be a testing ground for dimensional diagnosis of some form or other. That is, that you're going to be diagnosed on the extent to which you have, whether it's personality traits, personality disorders, personality prototypes, some form of dimensional diagnosis is clearly in the cards. Then there's trait diagnosis, which I'll describe in a moment, but which basically takes would be built out of what's called the Fivefactor model of personality, probably very loosely at this point, which is a model that actually also had many of its roots here at the University of Michigan in Donald Norman's work in a classic paper back from 1964 that came out of the psychology department here, people keep coming back to these 5 traits like neuroticism, extroversion, agreeableness, conscientiousness, openness to experience, etc. Then you've got prototype diagnosis, which I'm going to spend a little more time on because I want to show you some data on. And it does look like the ICD is clearly heading in the direction of the clinician's manual is probably going to be prototype-based or have something very much like prototypes. It's already close to that, and it's looking highly likely that will be the approach that's taken in ICD across disorders. That's not just for personality disorders. And there is now some fairly substantial chance that a prototype model might be used in DSM-4 as at least part of personality diagnosis to diagnose personality disorders. And I'm going to go through in a moment what a prototype model is. One more plug for the University of Michigan. I will mention that some early important work from a cognitive science standpoint and social cognitive standpoint on prototypes in the way clinicians actually diagnose patients was done here and published in the late 70s by Nancy Cantor when she was in the psychology department. So Michigan has actually had a lot to do with Michigan has a lot to do with personality disorders, but I'll just leave it at that. This is what a 5-factor model proposal for the agreeableness factor of DSM-5 looks like. This was developed by Tom Whittaker. basically what you do is you have agreeableness as a trait. You have a number of facets or subtraits under that, like trust, straightforwardness, etc. You would give each of them, it totals 35 across different facets. You give each of them a rating, and you end up with an overall rating. You can probably see, those of you who are clinicians, why this is not a popular model among clinicians. Most clinicians will say, actually, I'll give you a good example. I have a graduate student now who's finishing up, who sat in on the psychopathology class that I was teaching at the time, a graduate level course, and I showed a videotaped clinical diagnostic interview, which is a made-for-research version of what most good clinicians do in the first 2-3 hours with a patient in practice or hospital settings. So it gets a lot at people's stories that they tell about their lives, their histories, their relationships, and goes through all functional domains. And from that, the clinician then makes a number of ratings. But we got through the first 5 minutes of what was a 2.5-hour interview. I clicked off the videotape, and I said, all right, give this person a 5-factor diagnosis. And this student who was looking at Emory at the time to decide whether to come there raises his hand. He had studied the 5-factor model extensively for his undergraduate honors thesis, and he rattled off this beautiful 5-factor model, description of the patient. At which point I said, so are we done? Do we now know who this person is? And everyone kind of looked at each other like, oh, that's kind of a problem. Great that you can make the diagnosis in 5 minutes, but probably not very deep if you can make the diagnosis in 5 minutes. This is what a prototype model looks like. I'm going to show you, this case this is simply taking the criteria for panic disorder, and we did this for a particular study that we found actually that for mood and anxiety disorders, prototype diagnosis does as well or better, actually better at, in most cases, at predicting SCID diagnoses than does a clinician who's actually using the DSM-4 criteria as they're supposed to be used. But in this case, we just took the criteria for panic disorder, we wove them together thematically, and you'll see that here's a paragraph description or a prototype of a panic patient. Patients who match this prototype experience panic attacks characterized by discrete periods of intense fear or discomfort that develop abruptly. These episodes typically include intense physiological symptoms such as heart palpitations or accelerated heart rate, chest pain or discomfort, sweating, trembling or shaking, shortness of breath, or feelings of smothering or choking. One thing you will notice is that I did delete the jargon, and that's something that you'll see in the personality disorder diagnosis, personality disorder criteria that emerged empirically as most diagnostic. We actually got rid of the jargon, which can create a lot of unreliability in diagnosis in clinical practice. Goes on, panic episodes may also include other unpleasant sensations, such as dizziness or feeling unsteady, lightheaded or faint, ... So what your task is in prototype diagnosis is essentially, if I can find the laser, I'm probably aiming it at myself. There we go. Is what you're trying to do is to say basically to what degree does the person match this prototype? To what degree does the person's symptoms match this prototype? A 4 or a 5 means you give them a categorical diagnosis. You say, all right, they meet criteria for the disorder. That means very good match or good match. Then moderate match means they have features. Slight match means they have some minor features, and 1 means is the default. It means you don't have any features of the disorder at all. I'm actually have been working for some time, but not at the rate that I needed to get it, or would need to get it done, at trying to do this on the web electronically so that you could do a complete diagnosis of a patient in about 5 minutes by simply putting your cursor over any class of disorders that is relevant to the patient, and then locating the disorders that are most relevant, clicking on a number for them, going on to the next axis, doing the same thing, and basically printing off a report that gives you a profile of what your patient looks like on axis 1, axis 2, whatever other axes are included, as well as it can give you a printout of what the patient has or how high they are in various disorders and what symptoms were most reflective of that. So Advantage is a prototype diagnosis. It's simple. It's readily used. You can use it to make both dimensional and categorical diagnoses. It allows richer clinical description, which I'll show you in a moment. It better matches the way our minds actually naturally classify patients. This is what we gravitate towards. So the idea is, let's give clinicians personality prototypes that are all the same, that every clinician studies when they're in residency, whether they're in graduate school. And then they see patients over time, that they assimilate those patients to those prototypes. So they develop richer and richer prototypes, but they start out with shared prototypes. It avoids the dangers that you especially see in college students of underdiagnosis or overdiagnosis, because you don't have to underdiagnose because you're afraid of stigma. You're not likely to overdiagnose in a case like this, because you can give people features of various things that are descriptive of them, or you can pull out one or two of the features within one of the personality prototypes and say, this is on the problem list for this patient of things that I'd like to address over the next period of time that we're working together. There's a lot of data suggesting that clinicians find this much more useful than the alternatives. This is the first study that found it. These are various measures of clinical utility, and this is where the prototype system clinicians had just described their patient using a number of different systems, including the current DSM classification, as well as using a prototype model. And roughly 60 to 70%, depending on the metric, said they preferred the prototype model over the current Access 2 diagnosis, and only about 10%, 5 to 10%, preferred the current DSM, even though that's what they're familiar with. Other researchers have found exactly the same thing, except this is comparing prototype models with other models like the Fivefactor model, the FFM you'll see, and Cloninger's trait model. You'll see none of those does terribly well against DSM-4 in terms of clinical utility. A prototype model does substantially better. And Woo-Kyun An and her colleagues, cognitive scientists at Yale, recently published a paper that finds exactly the same thing. Five-factor model compared with the current DSM compared with a model of personality prototypes. So the question then is, can we derive prototypes empirically? That is, we know that clinicians prefer this way of diagnosing patients on Access 2. Can we derive them empirically? What I'm going to show you very as quickly as I can, because I'm already seeing my time is running out, is that, and I want to leave some time for Q&A, these are data from a national sample of 1,201 patients diagnosed by their clinicians with any form of personality pathology. We told them it does not have to meet criteria for Access 2. These are patients who are either experienced PhDs or MDs, psychologists or psychiatrists. In this particular study, we didn't include social workers or other mental health professionals. They described them using a number of measures. I'm going to mention one in particular, which is a personality pathology Q-sort, which is simply a way of describing a patient's personality on 200 different items, called the SWAP-2. We applied a form of factor analysis called Q-factor analysis that essentially, whereas factor analysis groups together items that are similar, it groups together types of people or cases that are similar to identify naturally occurring cases. We used the SWAP-2. These are experienced clinicians with an average of about 20 years experience. We had them randomly select a patient in their care by having them open their calendar to last week and either pick the first patient they saw that last Monday or the last patient on Friday. We figured that would control for both obsessive-compulsive people as well as impulsive borderline people. But our goal was just to have them randomly select a patient. We tested multiple solutions, algorithms, estimation procedures, etc., and we identified prototypes that were consistent across solutions and clinically and empirically coherent. I'm going to skip over how we did it and just go straight to what those prototypes are. I don't know how well you could read those, but I'll tell you what we found. We found 3 broad spectra of personality disorders, as opposed to currently we have cluster A, which is the odd cluster, cluster B, which is the impulsive erratic cluster, and cluster C, which is the anxious cluster. None of which, that was not, by the way, a well-developed empirical classification. This, alternatively, is completely empirically derived. So we found as the first 2 of them were internalizing and externalizing pathology. What to me was so exciting about that is exactly what researchers from a trait perspective are finding doing psychiatric research like Ken Kendler and Bob Krieger, they're finding exactly the same spectra using completely different items, using axis 1 as well as axis 2 symptoms, mostly axis 1. And they're finding 2 spectra, and then they find traits within those spectra. We're finding essentially, we looked for disorders within those spectra. The third spectrum was a borderline spectrum, which would not have been found in those previous studies because they didn't have the items in their item set to pick it up. And then we found a couple of personality or character styles, an obsessional and a hysteric histrionic. Now, let me just say something about the internalizing spectrum. It included depressive personality, anxious avoidant, dependent victimized, and schizoid schizotypal. Externalizing included antisocial, psychopathic, narcissistic, and paranoid, which if you think about it, share a number of qualities in common. And then we had a borderline spectrum that we could have divided up further, but it didn't really make a lot of sense because the overall diagnosis was so coherent. And then, as I mentioned, we found a couple of character styles. A couple of things to mention about this, and that is that within the spectrum, you would expect to see moderately high correlations. The intercorrelations are about 0.3 to 0.5 within the spectra. And across the spectra, you'd expect to see minimal correlations. And in fact, across spectra, the correlations average 0.0. So, and that's in a second sample where we cross-validated. So let me show you some examples. These are preliminary data. I just described those data to you, as well as I won't get into the coefficient alphas for the researchers who want to read it. I'm happy to get this to you. Actually, Trish, I believe, is happy to get this to you. In terms of validity, we actually looked at cross-correlations between the SWOT2 ratings made by an independent interviewer using the clinical diagnostic interview, the interview I described a moment ago, which looks a lot like what experienced clinicians do, except this is done by someone who doesn't know the patient for research purposes. And we then had the treating clinician independently use the same instrument to describe the person. Along the diagonal, that is, having the same disorder diagnosed by both the interview and by the treating clinician, on the diagonal we saw correlations of 0.5, and off the diagonal we saw correlations of 0.01 on the average. So, and this is in a second sample that is completely independent with different interviewers. So that's pretty good evidence that we're getting at something that is real and that exists. Let me just show you a few of these and then wrap up. Depressive personality. This, by the way, does not exist in DSM-4 or any of the prior editions. It did exist in DSM-2. The reason it doesn't exist in DSM, actually 3 or 4, was they already had avoidant, dependent, and borderline, and there was no way to construct a depressive that was not comorbid with those disorders. And the reason for that, actually, as it turns out, is there is, in fact, an internalizing spectrum where you would expect, quote-unquote, comorbidity because they're part of the same spectrum of pathology. Here's a description. These are completely empirically derived, except that we've ordered them in terms and thematically to make it easier for clinicians to use. So the summary statement: individuals with depressive personality are prone to feelings of depression and inadequacy. They tend to be self-critical or self-punitive, and they may be preoccupied with concerns about abandonment or loss. Does that sound familiar to many of you? Here's what the disorder actually looks like, and what you'll see. I'm not going to go through all of it, but I'll just give you a taste of it. Individuals who match this prototype tend to feel depressed or despondent and to feel inadequate, inferior, or a failure. They tend to find little pleasure or satisfaction in life's activities and to feel life has no meaning. They're insufficiently concerned with meeting their own needs, disavowing or squelching their hopes and desires to protect against disappointment. You can see there's some richness to the clinical description in all of this. They appear conflicted about experiencing pleasure, inhibiting feelings of excitement, joy, or pride. They may likewise be conflicted or inhibited about achievement or success, ... Antisocial psychopathic personality. Summary statement: individuals with this disorder exploit others, experience little remorse or harm for injury caused to others, and have poor impulse control. Here's a description of the disorders. Individuals who match this prototype take advantage of others, tend to lie or deceive, and to be manipulative. They show a reckless disregard for the rights, property, or safety of others. Their interpersonal relationships are fundamentally exploitative. They often appear to gain pleasure by being sadistic or aggressive towards others, and they may attempt to dominate significant others through intimidation or violence. Those, by the way, are correlates of the psychopathy construct, but are not part of the PCLR, which is the instrument used as the gold standard for assessing psychopathy. Other than that, and finding violence, which is found as a correlate of it, you'll see this description's almost identical to what was created independently with a long tradition in the psychopathy checklist. Things like they experience little remorse or harm for injury caused to others, and they lack empathy for others' needs and feelings. They appear impervious to consequences, ... Narcissistic personality disorder, I think you'll appreciate this one. Individuals who match this prototype have an exaggerated sense of self-importance. They feel privileged and entitled, expect preferential treatment, and seek to be the center of attention. They have fantasies of unlimited success, power, beauty, or talent, etc. I'm not going to go into this in any further detail. Borderline spectrum, don't have time to show you. Obsessional character style, if I were a little more obsessional, I would read it all to you, but I won't. Personality strengths index. Degree of match to this prototype provides a measure of adaptive psychological strengths. The more individuals match this prototype, they're more able to engage in meaningful and mature relationships, find meaning and satisfaction in life pursuits, and make effective use of their talents and abilities. And you can see individuals who match this prototype are capable of sustaining meaningful relationships, characterized by genuine intimacy and caring. Again, this is all empirically derived. We didn't have to gerrymander criteria to get these. This simply showed up empirically. They're empathic and responsive to others' needs and feelings, have the capacity to recognize alternative viewpoints, even when emotions are strong. Most of us wish we could say that about ourselves. Can we derive adolescent personality prototypes empirically? I won't get into all the details, other than that we did a very similar study with a national sample of 946 adolescent patients, aged 13 to 18, stratified random sample by age and gender. We applied the same data analytic procedures, and what did we find? We found 3 spectra, again, internalizing, externalizing, and borderline. We found 1 character style, which is a higher functioning style, which is obsessional. That was what distinguished those other 2 in the adult sample. And except for finding a slightly different configuration that were on the internalizing spectrum versus the borderline spectrum, we found identical disorders, except for an impulsive personality disorder that we found in adolescents that's associated more with delinquency. And we did not find a pure histrionic in this sample among adolescents. So they tended to either be more borderline or more impulsive. This is just as an illustration. The antisocial psychopathic personality looks almost identical to what I read you before with adults, showing that you can find this early on in adolescence. And again, these are strictly empirically derived. The adolescent personality pathology that we're describing, we're still finalizing these, but this is very close to what the final version will look like. So conclusions. For better or worse, our patients have personalities. That means that it makes sense probably to treat those personalities while we're treating their symptoms. Before treating a patient's symptoms, it's good to know the person who's hosting those symptoms. And that's something that I think is a really important point, is that personality is a crucible in which depression and other axis 1 disorders from which they often emerge. And most of us who do clinical work treat both the person and the symptoms of that person has. And if I were to, well, I'll skip over that part just in the interest of time. There are many ways a college student can come to depression, with implications for treatment response. Some of them have nothing to do with personality. I can tell you, when I used to supervise at the psychological clinic, we would often see patients who had been treated with every kind of psychotherapy under the sun, multiple medications, and who it was fairly obvious in the first session that they were struggling with the fact that they were gay. And they'd been treated, in all kinds of ways with standard formulations that people had made, but they weren't comfortable with being gay yet. And the treatment was obviously, a big chunk of it revolved around getting comfortable with being gay. Well, that's another path. It has nothing to do with personality. It has nothing to do with pathology. It has probably more to do with the pathology of our culture. But anyway, there are many ways to develop depression, and many of them do, in fact, cross through the pathway of personality. And finally, if you disagree with what I've said, no doubt you're passive-aggressive, but lucky for you, you're undiagnosable. Thank you very much. I believe we have some time, a few minutes for Q&A. I can't see terribly well out there because the lights are very bright, but I'll count on you to, if you want to go to, oh, thank you very much. This is a magical place, Rackham. If you want to go to a mic and ask a question or make a comment or be passive-aggressive or whatever you'd like to do, feel free. I think the reason to go to the mic is both so people can hear you and because I think this is being recorded.
I just have a question about the political nature of a new diagnostic manual, and those of us who care deeply about clinical work and aren't trying to get rich but just make a living, and only things that get paid for are for symptoms. So can we treat the person and the symptoms maybe going forward too? So we have a more, I don't know, honest discussion about what we care deeply about and how we help people with other powers that be and stakeholders, given that you're in the mix of it. Can you say something about that?
It's a great question, and I would hope that one of the outcomes of prototype diagnosis, if it does get included in either ICD or DSM-5 or both, will be that that third-party payers will consider anything that's diagnosed within that prototype, on that prototype scale, above maybe a 2, which is very, very slight, as something that would be worthy of treatment. Because in fact, those are we've done a number of analyses with these prototypes, looking at how they predict adaptive functioning, how well the person's actually functioning in the world, whether they're able to hold a job, whether they are committing violent crimes, whether they are abusing their spouse or partner, whether they are able to stay in close relationships. And what we find is that these personality diagnoses, treated dimensionally like this, actually predict adaptive functioning in ways that makes complete sense to pay for them. Unfortunately, our health system is one in which, if you're lucky enough to have employer-based health care, like those of you who are at Emory have, if you're going to be there a long time, it actually makes sense for your employer's insurance company to take care of this stuff. If they think you're just going to be there for a few months or for a year, it's probably not in their financial interest to do that. And so I would hope that a prototype model would actually be useful in that respect. Yeah.
Will you be making your slides available?
Trish, where is Trish?
Yes, they'll be posted on the website, Fresh Topics website.
Thank you.
Great, thank you. Yes.
Hi. First, I want to thank you for a great talk. I actually do personality disorder research with Steve Hubrick, so I don't think I've ever written anything that you're not referenced in. But
and I'm narcissistic, so I've never written on anything I'm not referencing.
But, as you're talking about the prototypes, it was interesting you actually showed the prototype for narcissism because, as you know, the proposal currently for the Axis 2 doesn't include that. In fact, they're halving the number from 10 to 5. So what are your thoughts about that actually going through? I've heard a lot of dissension at SPA. There was a panel with John Clark and Tom Whittaker, and it seemed like even on opposite sides of the traits and things like that, people are sort of saying there's maybe other ways to go. Do you think that change will happen, or do you think that the way the proposal is now, that's going to be the way it'll be in DSM-5?
Well, you've asked another great political question. It's the second political question about DSM-5. I have this bizarre belief that goes along with believing in things like, I don't believe in these others, but goes along with things like believing in alien abduction, apparently, that the diagnostic manual should be both clinically useful and empirically grounded. I know that's a bizarre belief, and I really apologize for bringing such strange ideas, but I would hope that what will happen with DSM-5, with Axis 2, will be that the empiricism that the work group, the Axis 2 work group, claims to be driven by is in fact at least at the table when making decisions. So that, for example, the 5 prototypes that they constructed to use that are going into field trials should never be going into field trials. They are completely made up out of whole cloth. They ignore the only empirical efforts that have ever been done to develop prototypes empirically, as opposed to the trait approaches, which were supposed to be based on the Fivefactor model, and if you look at them, they're getting awfully far from the Fivefactor model, so they lose the empiricism there as well. It would be nice to see the testing in field trials of our best available science about what traits ought to look like and what prototypes ought to look like. The Axis 2 work group has had a copy in their hands for many months of the data that I showed you. They know it's based on samples on a sample of above 1,200, and that it's been cross-validated in another NIMH sample. If they choose not to use it, there's not much I can do about that. I suspect a lot of the trait psychologists involved in the five-factor model are also very unhappy with the work group for not sticking closely to that either. They instead appear to be mostly making things up as they go along. So, is that different from prior editions of the DSM? And is it? I see John shaking his head. No. Is it different from other disorders? Maybe a little more, but not all that much. Hopefully that will change and evolve over the next couple of years. But who knows? We'll see when the next thing shows up on the website for DSM-5 of what the different work groups are coming up with. I do think, though, that it would certainly make sense for the work group to consider what are the best available, the best researched available data that could actually guide judgments on what should be in the manual. That seems to me like a fairly reasonable thing to consider, and thus far that doesn't seem to be at the top of the list. Maybe one or two more questions or comments?
Hello, my name is Aditi Sengupta, and I'm a Harvard Medical School Postgraduate Association member and also in the American College of Physicians. One question, or rather a suggestion that interested me about your telling about postgraduate year students, particularly residents, how much amount of stress they have, and the manifestations are usually disorders, psychological, and not only OCDs, but I have seen dropouts, as well as there was a good friend of mine who committed suicide. So I know how the pressure is. And in DSM-5, there is a adaptive psychological strengths, as you were telling. So how can this be implemented in the practical sense, particularly for the residents who are undergoing through this stress, besides being diagnosed, like coming for counseling on their own? But sometimes people do miss, and there are serious incidences happening. So how do you think this particular adaptive strengths can be implemented in this course curricula for the students' benefit?
It's a really good question, and I hope that DSM-5 includes, whether in a separate axis or part of a current axis, both a strong measure of stressful life events and perceived stress, as well as adaptive psychological strengths, because I think it's clear clinically that knowing what those strengths are is incredibly useful in helping mobilize those, whether it's helping getting your patient to take their meds, or whether it's working with someone psychotherapeutically. Knowing about and being able to actually diagnose isn't quite the right word for strengths, but to record in some way what those strengths are and to think about them in as you're thinking about a patient psychologically and psychiatrically seems to me to make a lot of sense. And empirically, as I mentioned before, adding adaptive psychological strengths adds substantially to prediction of how the person's actually functioning in the world. So, and whether they make suicide attempts or make a next suicide attempt if they've made one before, even controlling for prior suicide attempts. So I hope that's in the DSM-5. My guess is it might end up in Axis 2. If there is an Axis 2, that's another whole proposal, is just to get rid of Axis 2 entirely, which I hope is not the path that gets followed. But again, you never really know till these things happen.
Thank you very much.
I think we have time for one more comment or question. That's it.
I think she was waiting, but
oh, I'm sorry.
Yeah.
Types, I wanted to know what your thoughts are on how translatable these are to people of different ethnic backgrounds and cultures. And it seems like a lot of pathology and disorder is really framed by culture and society. And I'm curious also how much input from cross-cultural psychiatrists are put into the DSM diagnoses.
Those are also really, really good questions. One of the advantages of the kind of, I didn't get into the methodology of the Q-sort that we used to develop these diagnoses, but one of the advantages of it is that instead of being a rating system where you, for example, rate the extent to which a person has something, it's actually a ranking system where you have to rank order different psychological attributes as far as how much they're characteristic of this person. And the nice thing about a Q-sort like that is you're actually able to take into account things like if you're rating you're rating someone who is say comes from rural Peru, and there's an item about dependency. Well, if that person lived in say a white middle class American North American lived with their family until they were 35 in a multi-generational house. Actually, these days we'd say that's the economy. But normally we would say they might have a problem with dependency. For a Peruvian villager, that's not the case. So that item would actually end up really low in your description of that patient if that were in fact something that were culturally normative. So it's one of the real advantages of building a system like this with a Q-sort method. The other advantage is that, in fact, you can test out in different cultures whether you find similar solutions when you do a Q-factor analysis to see do you find different or similar disorders in different cultures. So, I don't know with the DSM-5 work group how much impact cultural psychiatry has had. I'm just thinking going on the list of names in my mind of people on that committee. I don't think it's terribly heavily represented, but it's a very bright, well-read group of people who I suspect have read widely, so I can't imagine they have not paid attention to that. But, there is a problem in the whole field of personality disorders that the way disorders were, the way international diagnosis has been done has essentially been to take the Western disorders and to try to develop structured interviews to use them elsewhere. And I think a better way, actually, is to try to develop them empirically elsewhere and see how well they match and see if there's some areas of real overlap, which some tentative data suggests that there is, but also there will likely be some areas where there's non-overlap, and that would make a lot of sense culturally.
Just one more.
John, do we have one
Yeah, so there's some interesting research done after the 9/11 attacks with the survivors of the 9/11 attacks that the people who scored the highest on narcissism, on scales of narcissism, actually had the least amount of depressive symptoms and PTSD. In general, there's a lot of research showing that deceptive and delusional repressive coping strategies might confer some psychological resiliency. So I'm just wondering if by pathologizing these traits that what might be pathological in one setting might actually be really adaptive in another, and how we can take those insights into practice and teaching.
Another good question. I'll answer it in two ways. One is that it is clearly adaptive if you're in Libya right now, for example. It is probably adaptive to be able to put things that you see behind you for the moment, as long as you're able to take them out again someday later and take another look at them. The flip side, though, is that of the data that you described is the same thing's been found for avoidant attachment styles, which is the people who report and self-report an avoidant attachment style, and just as people who self-report narcissism will also self-report very low levels of psychological and psychiatric symptoms. The problem with that is that there's a method variance or a method bias, which is that if you're self-reporting your degree of disturbance on psychiatric symptoms, and you're also self-reporting things like narcissism, narcissists like to see themselves as not having psychiatric symptoms. So we really don't know the extent to which, and same with people with avoidant attachment styles, they don't like to describe themselves as needing anybody or having any kind of anxiety. So, but when you measure them physiologically, you find that while undergoing a stressful interview, they're actually spiking off the charts in terms of anxiety. So I would caution about those kind of self-reports. And in fact, in the work that we've done, we have some measures that are, this is why we use expert informants, whether using using the clinical diagnostic interview or using experienced clinicians, because then we can include items that have content like tends to prefer to believe that he or she is without psychological symptoms when other indicators suggest that's not the case. And we find, for example, that's one of the defining features of obsessive-compulsive personality styles. So even though they will self-report that they have no symptoms, they are oozing anxiety in various kinds of other ways that they're covering with their obsessionality. And with that, I believe I will hand the mic over to Dr. Graydon.
Thank you. I think each of you know that you have just been treated to something special, and I actually would suggest that that comment applies to much of the past day and a half, the entire meeting. We have had a wonderful array of presenters. Some of them are still here. I think the real heroes are, I said this yesterday, are the ones who are delivering the care and trying to go back to campuses and make a difference to really do better with this next generation of graduates and others in our society. We need voices. We've had some take-home messages. I think that before I stop, I want to thank all of you and tell you that we'll do our best to be here next year. As always, we'll invite your ideas about what we should focus upon. And before doing anything to close, please join me in thanking Trish Meyer, who has really been responsible for the... And this one always has metaphorical significance for me. Drew made a lot of references to Michigan, but if you think of the dual images of this in this university, I can bid you goodbye by saying, go blue. So you have to think about that, don't you? So thank you, everyone.